It's my pleasure to be part of this exciting panel discussion on the mysteries of fascia and fascial plane blocks. What I'd like to cover in the next 20 minutes is an overview of the possible mechanisms of analgesia provided by fascial plane blocks as we understand them in 2021. I'm going to start by defining what fascial plane blocks are. It's basically any technique in which the target of our needle tip insertion is a potential space, the plane as we call it, between two fascial layers rather than aiming for a discrete nerve or plexus. We inject into this plane, distant from the actual nerves of interest, with the intention that the local anesthetic will spread to them. Now, this is not a new concept. Fascial plane blocks predate ultrasound. The fascia iliaca block, rectus sheath block were all landmark guided fascial plane blocks guided by surface anatomy and a sense of tactile pops through fascial layers. Nowadays, we use ultrasound to more precisely place our needle and local anesthetic into the fascial plane, and the number of described techniques has also exploded as a result, but the basic concept remains unchanged. Note that while I will frequently reference the TAP, PEX, and ESP block in this talk, most of the principles that I discuss apply generally to all the blocks. The first question to get out of the way is whether fascial plane blocks provide any meaningful clinical analgesic benefit. Basically, do they work or not? And if you don't believe that they work at all, then there isn't much point in discussing how they might work. The controversy mainly surrounds fascial plane blocks of the torso. However, I think there is pretty good evidence that they have an effect versus no block at all, and are comparable to other regional anesthetic techniques, and overall do provide meaningful benefit. We have multiple systematic reviews on the big three, TAP, PEX block, ESP blocks, that support this conclusion in a variety of clinical applications. Now, one of the things about fascial plane blocks is that they don't behave like the other regional anesthetic techniques that we're used to, like spinal anesthesia or brachial plexus block, where we obtain a dense sensory and motor block, which usually tells us that the block is working. In the case of fascial plane blocks, however, the pattern of sensory loss does not always seem to match the clinical analgesia it provides. For example, the TAP block is commonly used for somatic analgesia of incisions in the lower anterior abdominal wall, but the cutaneous sensory loss often doesn't match that. The erector spinae plane block, or ESP block, is even more controversial, with clinical evidence for analgesia of the anterolateral and anterior torso, but some studies showing only cutaneous loss over the posterior torso. There are surprisingly few studies that have examined the sensory loss associated with PEX blocks, so I can't comment there. But nevertheless, trying to reconcile these observations with the opioid sparing and lower pain scores that are reported in clinical studies is one of the main drivers behind the question of how they actually work. But if we really think about it, the lack of a dense sensory and motor block is perfectly understandable if we realize that in a supraclavicular block, for example, we're depositing 30 mils of local anesthetic right next to the brachial plexus, whereas in a fascial plane block, like the TAP or ESP block, we're depositing, say, 20 mils, a significant distance away from the target nerves. So it's logical that only a fraction of that volume and mass is actually going to reach those nerves. And it's also very clear from studies that have been done that neuroconduction blockade is a function of the concentration or, in fact, the mass of local anesthetic that the axons are exposed to. It's also clear that different nerve fibers have different sensitivities to local anesthetic blockade. And in particular, unmyelinated and smaller myelinated fibers that transmit thermal and nociceptive stimuli are blocked at lower local anesthetic concentrations than the larger myelinated fibers that serve motor and other sensory functions. So let's look at what happens to local anesthetic once it's been injected into a fascial plane. There are two major pathways of spread: local dispersion through the surrounding tissues, and vascular uptake and dispersion throughout the body. Local dispersion initially occurs via bulk flow. And bulk flow is the movement of a body of fluid particles driven by a pressure gradient. This is influenced by physical forces, including ejection pressure, elastic recoil of distending fascial layers, and sliding of fascial layers over each other with body movement. Initial dispersion by bulk flow is contained by the fascia and spreads in the path of least resistance, which is within the plane between the two fascial layers. But if the pressure is great enough, either from injection or from the elastic recoil of the distended fascial plane, the local anesthetic fluid may be pushed through the fascial layers into the adjacent tissue compartment. And this may be muscle or a fat-filled space like the paravertebral or intercostal space. And that brings me to my next point, that fascia is a porous structure. So this is a histological section of the human abdominal wall. At a microscopic level, fascia, which has been colored green here for visibility, is a woven lattice work of collagen fibers filled with a hydrated gel-like glycosaminoglycan matrix. Now this gel is lost during the fixation process, so the lattice work is not so evident. This artistic rendering of the superficial and deep fascias under the skin illustrates this a little bit better. And it may also be useful to think of fascia like a Gore-Tex membrane. It's impermeable to large aggregations of fluid which it sheds off its surface, just like fascia contains the initial injection of local anesthetic, but the microporous structure permits the smaller aggregations of the fluid to pass through. And at a more macroscopic level, muscles and fascia are pierced by perforating vessel and nerve branches that ascend to supply more superficial tissues. And these perforations provide additional anatomical pathways for local anesthetic fluid to travel along and thus pass from one fascial plane to another. Bulk flow is a relatively fast phase of dispersion. A slower phase of dispersion is by diffusion, which is the movement of fluid particles from a region of higher to lower concentration. And this is driven by a concentration gradient and depends on particle random walk or Brownian motion. Overall, local anesthetic dispersion and progression of the accompanying neuroblockade can continue over a much longer period than the 30 to 45 minutes that are often used in studies, as was shown here in an elegant MRI study of tap blocks by Jens Borglum and colleagues. The second pathway for dispersion of local anesthetic in fascial plane blocks is by vascular absorption. Local anesthetic that enters into the vascular system can act at any anatomical site with a blood supply by diffusing into these tissues. The two clinical models that would be familiar to us are IV lidocaine infusion, but also IV regional anesthesia. Here again, we see the impact of local anesthetic concentration and mass that actually reaches effect sites in nerve endings and accents. The plasma concentration is obviously going to be much higher in IVRA and thus result in a greater tissue penetration and more pronounced conduction block. Hence, we have the ability to provide surgical anesthesia with IVRA, whereas we would never expect to see that with intravenous lidocaine infusion. Again, though, as we've all experienced, even IVRA does not provide complete anesthesia 100% of the time. Nothing is ever guaranteed in life, and variability is a fundamental biological principle. So now that we understand how the local anesthetic that we inject in fascial plane blocks is distributed, we can ask where they might be acting to provide analgesia. I like this illustration of the pain pathway that I found on SlideShare, which I'm going to borrow. So first of all, local anesthetic can act at peripheral nerve endings in the surrounding tissues at the site of injection. Imaging studies clearly show that the muscles surrounding the fascial plane of injection are infiltrated by the local anesthetic. And this is relevant because traumatized muscles are a significant source of pain, as I'm sure all of us have experienced at some time or other. Examples from clinical practice include scenarios where there is pathology in the vicinity of the fascial plane block injection. So for example, rib fractures where we can do a serratus anterior plane block, rectus sheath block for midline incisions, or the ESP block for musculofascial back pain. Second, local anesthetic can act on the axons of peripheral nerves that are traveling either within or through the plane of injection. And I think this is pretty straightforward and uncontroversial. What is more controversial, though, is local anesthetic penetration out of the plane of injection and into adjacent tissues and compartments. And this has been called into question mainly with regard to the paraspinal fascial plane blocks, which purport to work on the ventral ramus dorsal root ganglion and the spinal nerve that run through the paravertebral space and the region of the intervertebral foramina. However, a similar question has also been posed for the serratus anterior plane block. Does that penetrate to intercostal nerves? Although the findings of this one cadaveric study did not support this, this may in fact be quite plausible. We've already discussed the fact that fascia is actually a porous structure perforated by multiple nerves and vessels through which fluid can pass. And in the case of intercostal nerves, there are multiple muscular branches that arise to pierce and supply the different layers of the chest wall. Fluid spread across fascial layers may be even more likely in the presence of surgery or trauma. Unlike the earlier study, Johnson and colleagues here observed dye spread to intercostal nerves following a deep serratus anterior plane block when they used it in a cadaveric model of rib fractures. Putting this together with the clinical results observed in patients, I think it's quite likely that physical spread of local anesthetic in living subjects is going to be much more extensive than is demonstrated in most cadaver studies. Let me briefly offer my opinion on the local dispersion of local anesthetic in paraspinal blocks to the paravertebral space. There's no question that in paraspinal blocks such as the ESP, there is spread within the erector spinae muscle itself, and this is well demonstrated in both cadavers as well as living subjects. This consistently reaches and anesthetizes peripheral nerve endings within muscle, as I described earlier, but also anesthetizes the dorsal rami of the spinal nerves, which innervate the spine itself and the musculoskeletal tissues of the back. And this is what underpins the emerging role of the ESP block in spine surgery and back pain. What is the subject of debate is whether the injectate spreads anteriorly into the paravertebral space as we initially claim, or whether it only spreads in the superficial tissues, perhaps involving lateral cutaneous nerve branches, as was shown by Ivanusik and colleagues in several other cadaveric studies. However, this doesn't really match with what we see in live patients. So this CT scan from our initial report on ESP block shows that lateral spread of the injectate is limited, and subsequent imaging studies in live patients consistently demonstrate that anterior spread into the intervertebral foramina and paravertebral space can and does occur. Now, much is also made about the absence of staining of ventral rami in the negative cadaveric studies, and this is a figure from one such study by Ivanusik and colleagues. They point out that the ventral ramus was almost never stained, just the dorsal ramus. However, if you look a little more closely, you can see that the injectate has tracked along the dorsal ramus all the way to stain the spinal nerve root and the dorsal root ganglion that sits in the intervertebral foramen. Now, the same sensory fibers from the anterior torso that pass through the intercostal nerves and the ventral ramus also pass through the dorsal root ganglion. So absence of ventral rami staining doesn't mean that we have failed to block the sensory afferents of intercostal nerves, but rather that we have done so further upstream. Another cadaveric study published just this year in 2021 provides further evidence that the local anesthetic does track along the dorsal rami and its accompanying vessels to reach the intervertebral foramen, with microscopic sections showing dye sheathing the blood vessels and the nerves in the space. Finally, this cadaveric cross-section at the mid-thoracic level further illustrates the lack of impenetrable barriers to fluid spread in either a retrolaminar or ESP block. We see the edge of the lamina here and the tip of the transverse process. We also see the dorsal root ganglion sitting in the intervertebral foramen. A fat-filled pathway connects the paraspinal planes of injection and the compartment of the paravertebral space and the intervertebral foramina. In addition, the dorsal rami and accompanying vessels that perforate the intertransverse tissues provide an additional pathway for spread, as I've already described. Most importantly, we see this in imaging studies in living subjects, with clear evidence of radiological contrast spreading into the paravertebral space, around intervertebral foramina, and even into the epidural space. However, what is suggested by the intensity of the signal is that most of the injectate remains within the muscle, and only a fraction of it penetrates deeper. It's likely that the size of this fraction is variable. The question then becomes, is this fractional amount enough to have a clinically meaningful effect? I think there is a strong case for this based on the evidence that we have for a meaningful differential sensitivity of nerve fibers to local anesthetic, which I've already touched on, and which has also been demonstrated in various studies. Any of us who have had minor procedures done under local anesthesia will also be personally familiar with the phenomenon of analgesia, even while we retain some sensation and awareness of deep pressure. But if you're still uncomfortable with buying into the local dispersion theory, particularly with regard to paraspinal blocks, we can always fall back on the systemic effect of local anesthetic absorbed into the vascular system. The more proximal sites of action along the pain pathway can really only be reached by systemic local anesthetic that's dispersed by the vascular system. And this includes the dorsal horn of the spinal cord and supraspinal structures such as the thalamus. And these are thought to be important in the mechanism of action of IV lidocaine infusion. IV lidocaine may have an effect on voltage-gated ion channels at nerve endings, similar to what we see with IV regional anesthesia. Or it may act at the dorsal horn of the spinal cord where it modulates neurotransmitter release and central sensitization to pain. And as I've said, it may also act at supraspinal structures, and in particular the ventrobasal thalamus, which is a relay station for pain and will thus reduce the perception of pain. There are numerous pharmacological targets beyond just sodium and ion channels that have been identified for IV lidocaine in laboratory studies. However, the relative importance of these in clinical analgesia is still unknown. And one reason is that the concentrations required for activation of many of these receptors exceeds the concentration that is normally achieved at clinically used doses of IV lidocaine infusion, which is shown here as the green bar. What we do know, however, is that there is rapid and significant uptake of local anesthetic after fascial plane blocks, and that these can result in levels consistent with IV infusion at clinically relevant doses. The available data for ESP blocks, for example, shows that a single injection does produce plasma concentrations in the range associated with therapeutic IV lidocaine. This is not sustained for more than a few hours, however, which does call into question the impact of the contribution of systemic local. Now, continuous catheter infusion will sustain these levels and in fact cause them to even gradually rise, so this mechanism may be more relevant with continuous fascial plane block techniques. Nevertheless, there are a couple more things to consider though. The first is whether ropivacaine and bupivacaine, which are the local anesthetics most commonly used in fascial plane blocks, will have the same systemic effects as lidocaine. Now, this has not been directly studied because of the potential for cardiotoxicity, but laboratory studies do indicate that they have similar interactions at ion channels and neurotransmitter receptors in peripheral as well as dorsal horn neurons. So it's reasonable to expect that their systemic analgesic effects should be comparable. The second and more fundamental question is, how large and meaningful is the analgesic effect of IV lidocaine? The analgesic effect of IV lidocaine infusions is actually itself somewhat controversial, although I must say it doesn't seem to attract the same heated discussion that paraspinal blocks and fascial plane blocks do. A 2018 Cochrane review did reach a rather guarded conclusion, remarking that it was uncertain whether IV perioperative lidocaine compared to placebo or no treatment has any effect in improving pain intensity, opiate consumption, or associated adverse effects. And hot off the press, this international consensus statement summarizes the available evidence to try and answer this question, but unfortunately was unable to give us a definitive answer, suggesting instead that it may depend somewhat on the setting in which it is used. At the same time, we do have retrospective studies such as this one, which suggest that IV lidocaine infusion may be equivalent to epidural analgesia for rib fracture analgesia. Now, note how the distribution of pain scores shifts towards the lower end of the range with both interventions over time. Although, equally note that even with epidurals, you will always have some patients who continue to have pain scores in the 5 to 7 range. The issue with IV systemic lidocaine and its action may actually be quite similar to the one that plagues the local dispersion theory of fascial plane and paraspinal blocks. And this is the fact that there is significant inter-individual variation. Just as we see variability in the degree of physical spread of injectate, we also see tremendous variability in the plasma concentrations that are achieved after fascial plane blocks. And these are only evident if you look beyond the plotted means at the whiskers on the graph or the spread of individual data that's reported in various studies. Now, a few investigators have talked about the rich sympathetic innervation of fascia, such as the thoracolumbar fascia, and implied that this may play a role in the clinical analgesia of blocks, such as the quadratus lumborum and ESP blocks. I do not dispute the sensory and sympathetic innervation of fascia, and certainly local anesthetic injected in the vicinity of fascia will anesthetize this fascia, and thus relieve pain that originates from these tissues. However, I do not believe that it is relevant to the relief of pain at other distant anatomical sites. Specifically, blocking nerve endings in the thoracolumbar fascia, for example with QL or ESP blocks, will not modulate upstream signals and will not contribute to analgesia of the abdominal viscera or abdominal wall, as these are completely separate pathways. More importantly, we need to realize that sympathetic nerve fibers are not the same as the visceral sensory afferents that transmit noxious stimuli and other sensory input from intrathoracic and intra-abdominal viscera. Sympathetic neurons are purely efferent, and so blocking these fibers or their nerve endings will have no effect on the afferent transmission of painful stimuli. However, they do travel in the same anatomical nerves and plexi as these visceral sensory afferents, so performing a so-called sympathetic block, like a celiac plexus block, will produce visceral analgesia, but this is not due to blockade of the sympathetic fibers per se. Now, the visceral afferents converge with somatic afferents in the dorsal root ganglion, which is why paraspinal blocks, such as the ESP, which can produce local anesthetic spread to this area, can have visceral analgesic effects. And there is evidence of this from case reports of pain relief in purely visceral pain syndromes such as acute appendicitis and pancreatitis. There are other esoteric mechanisms that have been put forward, which I must say as yet seem implausible. Now, one is an immunomodulatory mechanism based on the observation from our porcine studies. The investigators performed ESP blocks with methylene blue in live pigs, which were then sacrificed. And what they found was dye spread to the dorsal rami, but also to prevertebral lymph nodes. It's true that there's been recent interest in lymphatic drug delivery as a therapeutic modality. However, I think it's unlikely that any anti-inflammatory or immunomodulatory effect can account for the acute and rapid pain relief that is observed with fascial plane blocks. And we do lay out the reasons for these in a little bit more detail in our article on the mechanisms of the ESP block. Now, another postulated mechanism is an effect produced by physical needling of the fascia, similar to that reported with acupuncture. However, most acupuncture involves needle insertion into superficial tissues, not deep fascia, and it's also been shown that local anesthetic injection abolishes any effect of acupuncture. So again, I think this is unlikely to be relevant here. Ultimately, the relative contribution of local dispersion and local effects versus vascular dispersion with systemic effects is not easy to determine at this time, and it may also be different for different scenarios and different fascial plane blocks. But it is my opinion that the theoretical considerations in evidence base suggest that the local effect probably predominates. Thank you very much, and I'm going to hand this back to our chair.